Thank you and welcome to this webinar on sexual dysfunction in female with oncological diseases, oncological cancer. This is the second webinar of the special interest group from the sexual health special interest group from the EAUN. During this webinar, 4 topics will be accounted to on the female sexuality. The first topic will be on the female anatomy and physiology. The second topic will be on the impacts of cancer on female sexual well-being from the nurse perspective. The third topic is on the same issue, but then from the patient's perspective. And the last topic we will be announcing for this evening is on the counseling on sexual function, the psychological and emotional impacts on the woman and her partner. I will start with the first topic in this webinar, which will be done by myself. So I will start the presentation and share the screen. Let me see to start the presentation. Let me see. No, this is not the right screen. I'm sorry. I will set it up again. This is the screen I have to share. So the first issue is on the sexual well-being, the anatomy and physiology. I first have to announce also this webinar is accredited by 1 CNA point. You will be receiving a certificate after this webinar for tomorrow or the day after. And my first start with the female anatomy and the urogenital organs. And afterwards, I'll tell you a bit more on the physiology of the female reproductive organs. To start with the ovaries, a woman has 2 ovaries. They're oval in form, about 4 by 1.5 and 1 centimeters large. So that's rather small. And they weigh about 2.5 to 7.5 grams. I don't know if you can see an arrow, but on the right and the left side of the uterus, there you can see the ovaries, and they are connected from the cortex with the tunica albuginea, and that's a thin layer, which holds the ovaries in the right place. Inside the ovaries, there are follicles with eggs inside, and a woman has all their eggs inside when she's developing in the uterus as a baby. So the eggs will grow and develop one by one during the fertile period. To hold the ovaries in place, it's connected with ligaments to the uterus. So that's this part. And the eggs will be transported through the fallopian tubes. There are 2 of them, of course, as there are 2 ovaries. And the egg is transported through the tubes to the uterus. And only 1 egg is completely developing once every month. So 1 from the left or from the right, and that's different. Sometimes from the right, sometimes from the left, and it's pushed forward by cilia, and that's a kind of tissue which can push the egg towards the uterus. And that takes a few hours to some days, and in this period, the woman is fertile. So then the egg can be connected to to the semen, if that's present, of course. And then we move on further to the uterus. The uterus is, of course, the most, you feel like it's the most important part of your genital organs inside your body. Normally, when you're not pregnant, it has a size of 5 to 10 centimeters, and it's the size of a mandarin. It's pear-shaped, so it's rather small. And during the pregnancy, of course, it can develop a lot. It grows a lot, and the weight is then at the end of the pregnancy almost 1 kilo. So that's a lot more than when you're not pregnant. And it's placed in the small pelvic behind the bladder, as you can see in the upper picture. When you look more into the wall of the uterus, there's a ligament latum uteri, as you call it in Latin, and it has the wall of the uterus has 2 layers, and they're connected by a smooth muscle. So that's rather it's possible to expand a lot for having a baby inside the uterus. And the inner layer, so the inner side where the baby also is, and I don't know the English word, I'm sorry. It's the endometrium, and that can also cause issues when you some older women, but that's more a gynecological problem, so we won't attend to that. The lower part of the uterus, it's called the cervix, and that's the part that's connected to the vagina, and that's about 4 centimeters long, 3 centimeters in diameter, and it's the lower part of the uterus. As I say, it's connected to the vagina, so it's this part of the uterus. And on the inner side, there's an opening from the uterus here, and on the other side, there's also a small opening through which the baby can come down, of course, but also from which the sperm is pushed inside the uterus to go through to the tubes to connect to the egg, to fertilize the egg. The epithelial is about 2 layers, 2 different kind of layers. It's a squamous epithelium, and it's this is squamous part, and this is the columnar part, and that means that has 2 kind of different functions. And also the cervix has a wall of smooth muscle tissue. And when you get to the last part of the internal genital organs of the woman, that's the vagina. We call it as a H-shaped model. You see it in the lower picture a little bit more. It's about 8 to 10 centimeters long, and it's also containing the vaginal introitus and covered by some mucosal tissue that's called the hymen. And that's some cultures that's very important part. And when you see at the left side, that's the vagina when a woman is fertile, and on the right side, there you see how the vagina is, and that's a little bit smaller, is shrinking a little bit after the menopausal period. And the vagina is also surrounded by the pelvic floor muscles. So therefore you can also squeeze a little bit with the muscles and contract the vagina. And therefore also with birth, the vagina has to get wider, so the muscles, the pelvic muscles, has to get relaxed more. And the body can also do that in a very good way most of the times. When you come to the outer side of the external genital organs. Then you see the vulva with the labia majora and the labia minora. And the mons pubis, as it calls, that's this part where the clitoris is also located, and where the meatus of the urethra also be found. That's over here. I shall. Here, this is the clitoris, and this is the meatus, and it's surrounded with the pudendal arteries and the internal pudendal veins. So it's well good with blood inside. And also the nerves are located here that take care of the feeling, and therefore the clitoris has a lot of feeling inside because of a lot of nerves. This is a picture I got from Wikipedia, but it shows also the location of the clitoris, where it's located. And actually the clitoris is the end of a whole organ, which is inside, which you see in this lower part. And actually when you compare it to the penis of a man, then the clitoris is actually the glans. So the most distal part of the penis, and therefore it's very sensitive. And the whole part, so this whole part is about 7 centimeters long. So it's much longer than what you actually see on the outer side of the body. When you go to the physiology of the female genital organs, then the ovary and the fallopian tube, that's in the ovary, the development of the follicle of the egg is taking place, and once a month, because of stimulation of hormones like the FSH, the follicle stimulating hormone, and the LH hormone that takes care of maturating the follicle, the egg, and takes care of the ovulation, so letting the egg into the fallopian tube and transport it to the uterus. And there the egg goes, and when it's fertilized, into the wall of the uterus and develop it to an embryo, and that's all regulated by different kind of hormones like progesterone, estrogen, that kind of hormones. And in the uterus, that's of course the part where the baby is carried, and it's developing, starts within the wall at one side of the uterus, and there it will developing with a placenta, of course, and everything that's belonging to that. And as you know, after about 9 months, baby is completely developed and can be born. When there's no fertilization of an egg, then after a few days the menstruation starts. So normally that's exactly about 2 weeks after the follicle has the egg is matured and developed and gone to the transported from the fallopian tube. In the vagina, that's also an important part, of course, of the body. There's a floor, kind of the tissue takes care of some mucosa. That's also comes from the cervix, but also developing in the vagina. It's a bit of it has a low pH, and therefore bacteria has not that much part of getting an infection, but so it takes care of protection, and therefore the semen and the liquid coming from the prostate in a man, it has a higher pH to be able for the semen to get progress and to swim towards the egg, because they don't have a good the low pH is not a good surrounding for the semen, and therefore it has to be get a bit higher when there's a sperm. As we know, the vagina gets shorter after menopause, and the mucosa is getting less, and therefore it's getting shorter and thinner. And as the last parts, the outer sides, the labia majora, they will cover the vulva and therefore protect it a little bit. And the labia minora and the clitoris, they're of very importance for the sexual arousal of the woman. And as we know, when there's a sexual arousal, the glans clitoris, or as we see this part, that's the small outer part, that is swelling, and that will have the sensitive feeling to get aroused and get to a higher point. And then also most of the times there's some contraction of the pelvic muscle during that period. This was my last slide. If you want to ask questions, you can put them in the chat or the Q&A, and we will answer them or during this session or at the end of the last presentation. Thank you. And I will stop sharing my screen. And then the next presenter, let me see if I can put it here. Yeah. Let me see if I'm doing this right. Yeah. For our next presenter, that will be Rebecca, and she will get into an overview of the impacts of the cancer on female sexual well-being from the nurse perspective. Rebecca, the floor is yours.
Thank you, Jeanette. Hello, everybody. Oh, sorry, I can't share my screen at the moment. Bear with me. Jeanette, I seem to have your screen up. I wonder if you're able to stop sharing. Is there anybody available for technical support? Ah, there we go. Great. Thank you. Let's wait for that to load up. Hopefully you can see that okay now. So I'm Rebecca. I'm a nurse practitioner in London. Thank you for inviting me to talk today. And thank you, Jeanette, for that excellent presentation. I'm going to give a nurse perspective on female sexual well-being, and the majority of the patients in my practice are patients with bladder cancer, so I'll have a bladder cancer perspective throughout this presentation. I've got no conflicts to declare. Just a brief overview of the contents of my presentation. So we're going to talk about the impact of cancer on a woman's sexual well-being and function, how we measure it. Are women bothered by changes in sexual function while they have cancer? I think that's an important question to ask. And how can we better address concerns within our clinical practice? As we talk today, I want you to think about this case study. So bear in mind Belinda, she's a 63-year-old female. She has a T2 bladder cancer, and it's been recommended that she has a cystectomy. Her context is that she works as a journalist. She has one grown-up son, lives with her male partner of 10 years, and enjoys an active lifestyle. So first thing to say is that female sexual function, or dysfunction rather, is a prevalent issue. It's in the general population, and it's estimated to affect around 40% of the general adult female population at any one time. So what happens to female sexual function during illness? Female sexual function is complex, desire is complex, and the conditions to engage need to be right for it to take place. So if the physical and psychological conditions are not optimal, the female sexual response cycle, may be broken in the context of illness. And for example, in chronic illness, sexual dysfunction is more common. And in bladder cancer, which is the example I give here, for instance, it's estimated to affect up to 75% of female patients. Across the cancer spectrum more broadly, there's an average, the estimated or quoted average is around 66%. So let's address what is female sexual dysfunction, or FSD. It can be an arousal, orgasmic, or pain disorder. It can be physical or psychosocial in its presentation and causation. And symptoms of FSD can include loss of libido, vaginal dryness, difficulty achieving orgasm, or pain, otherwise known as dyspareunia in the medical texts. So what are the common causes? And let's consider this in the context of cancer. Menopause plays a significant part. And if you consider, cancer and its treatment, this may be a treatment-induced menopause, or it could be a natural menopause. Either way, symptoms are similar, and it can contribute to, loss of desire or reduced libido, vaginal atrophy, and vaginal dryness. Medications that we give our patients, cytotoxic chemotherapy may be a factor in terms of, the patient's treatment. And, people may be concerned about contaminating a partner. So appropriate counselling around, ways to engage and suitable protection to mitigate those risks would be appropriate. But other medications that we may be giving our patients commonly in cancer may also contribute, to FSD. And, some of the more common antidepressants, for instance, like SSRIs, can contribute to a degree of sexual dysfunction. When we think about surgery, particularly when you're talking about bladder cancer, our patients may be having pelvic surgery. And certainly for cystectomy, for instance, that pelvic surgery may involve removal of the gynecological organs, or have an impact on the anterior vaginal wall. So, and if you think about the anatomy that Jeanette has just very clearly explained to us, there's a close relationship between the urethra and the anterior vaginal wall. But also there's impact of estrogen if you're taking away the gynecological organs. Then we've got circulatory disorders that may affect blood supply to the clitoris and vagina. It's clearly going to have an impact on physical function. And then other sort of comorbid conditions like multiple sclerosis, arthritis, even diabetes can have an impact on sexual function. And then the psychological factors can play a big impact, particularly on female sexual function, and it can impact on desire, enjoyment, body image, and self-esteem. What is the impact of FSD? Evidence tells us it has, can have a significant impact on overall well-being, an impact on body image and self-esteem. It can affect intimate relationships and therefore quality of life after cancer. So are we good at measuring it? How do we measure it? Let's start with that. So we could start by taking a baseline measure of sexual function. There are several patient-reported outcome measures. My understanding is that they're not routinely collected in clinical practice in most centres, but they're used quite commonly in research. What we found with two recent systematic reviews that were conducted in bladder cancer is that the PROMs they're kind of used inconsistently, and they don't accurately capture that psychometric data that's essential for understanding female sexual function. For instance, the more commonly used PROM perhaps is the Female Sexual Function Index. It's sometimes criticised for not capturing data for women who aren't sexually active, and therefore you're missing a proportion of women who aren't sexually active at the time that the measure is taken, but perhaps want to be, and therefore it's failing to capture accurately the picture for women in our care. It's also, the FSFI is also sort of criticised for being heteronormative, so it doesn't necessarily capture information on people in same-sex relationships, for instance. So the table here highlights the more commonly used PROMs and how many questions relate to sexual function. A lot of the questions are common to both men and women, but actually, therefore it's not really reflecting that sort of complexity of female function. The more sort of recent EORTC SHQ22 will hopefully address some of this gap. And a lot of the EORTC modules are used quite commonly in research, but perhaps less commonly in clinical practice. So it's something to think about. So in Belinda's case, we've established that she will be bothered by changes to her sexual function. However, the literature doesn't always establish the correlation between sexual function issues and symptom bother. But what we know from the research in bladder cancer is that actually we're not very good at measuring symptom bother. So if we're not very good at understanding the patient experience of sexual well-being, are we any good at talking about it with our patients? And there are a few studies examining this. This is a key study from the USA asking clinicians about counselling of patients who are being prepared for cystectomy. And it found that counselling for female patients was consistently less likely in several key areas. Firstly, baseline activity. Secondly, risks of sexual dysfunction associated with surgery, options for nerve sparing, and then in the sort of post-operative setting, the post-operative sexual health counselling. So in clinical practice, age is often cited as a reason why sexual function isn't addressed. However, there's no evidence to tell us that older women, don't want to be counselled on these issues, or that intimate relationships are less important to them. And certainly in my own practice, I have many conversations with older women who are concerned about this aspect of care. Research from the UK tells us that healthcare professionals often lack confidence to address these issues in clinical practice. Whether this is due to lack of knowledge or training in how to manage concerns, or embarrassment on how to approach the subject, or if it's because the focus is on illness rather than overall well-being. We don't know. But let's call it the intimacy mismatch. So the patient waits for the clinician to approach the subject and to have the issue legitimised during a conversation. However, the clinician may wait for permission from the patient to start that conversation. So what can we do? And we'll learn more about this from Marika in the final talk this evening. But perhaps we could start with just asking that question, and a door opener to that conversation could be the introduction of a PROM, or, asking a simple question during a consultation. Is this something you're worried about? How can we help address this issue? But either way, just by starting with that question, you're legitimizing that patient's concern. So in Belinda's case, we've asked those questions and established that she's having a cystectomy, and we know that sexual function is important to her. The loss of sexual function will cause her bother and potential distress. We've opened the door and began appropriate counselling to support her holistic needs. The key thing we can do is to open that conversation with our patients, and depending on our role, specialist area of practice, any enhanced training that we may have had, we may be able to advise on certain aspects of sexual well-being. But beyond this, if we recognise a problem, then we must refer to a specialist service such as psychosexual therapy. Thank you very much. I'm going to pass over to Susan now. Thank you.
you, Suzanne, Rebecca, for this excellent lecture. And as you said, Suzanne, you're the next speaker. Suzanne is a patient who will talk us through the patient's perspective of this issue. Suzanne, the floor is yours.
Thank you. Can I ask tech support if they can put the video, my video, or here we go. I've got the presentation. Okay, so I'm Susan, and I'm going to be.
Excuse me, Susan. Can you?
We're there.
Perfect.
Yeah. Okay, we're there. First of all, I'd like to thank the EAUN for inviting me to speak. Thank you to Jeanette and Rebecca for your great presentations. So I'm Susan, and I'm going to be talking about the patient's perspective as I am a bladder cancer survivor. Could I have the next slide, please? So following my diagnosis, which was of stage 3 high-grade advanced bladder cancer, I underwent a radical cystectomy in November 2017. Bladder cancer is the 5th most common cancer in Europe. So initially, after a lot of tests and a big test that's known as a TURBT, following that, I was actually given my cancer diagnosis. And I was given a very brief summary to prepare me for the operation of a radical cystectomy. And this was the bit of a shock and the impact of actually losing the organ, namely the bladder, and the creation of a stoma. So that was on day 1 when I met with my consultant. I understandably had a lot of questions. So on day 2, I made another appointment, and my son, who was in his mid-30s, came along with me to find out sort of what was happening with his mum's cancer diagnosis. So we were talking to the consultant, and it was casually dropped into the conversation that, oh, by the way, your vagina will be closed. Not shortened, not affected, but closed. And I was a bit confused at that. What did that actually mean? For me personally, I wanted to live. So I had this tremendous fight that kicked in me to survive cancer, no matter what. I'd face all the obstacles and everything else afterwards, but I just wanted to survive. So I'm happy to report, here I am, 7 years on. I'm now a patient advocate and a survivor. So let's talk about survivorship. What is actually meant by cancer survivorship? So we focus on the health and well-being of a person with cancer from the time of their diagnosis until the end of life. Now, this includes physical, mental, emotional, social, and the financial effects of cancer. And that begins at the diagnosis and will continue throughout treatment and beyond. But there's a few omissions here, because for women, sexual health significantly impacts our overall health. But the subject is so taboo. So I now advocate that survivorship must and importantly include relationships, partners, carers, and importantly, sexual well-being. Next slide, please. So what is actual surviving beyond the radical cystectomy? Well, we have to obviously learn to live with a stoma, which is hard enough in itself. This is life-changing surgery. Quite importantly, and for me, I lost a lot of body parts. 19 actually were taken from me with the total operation. But apart from the loss of the female body parts, I very sadly had this tremendous loss of me. I understand totally that not everybody's the same, and we shouldn't prejudge. Lots of people could look at me and say, well, she was diagnosed at the age of 63. She's had children. She's been through the menopause. And now you can look at me and I've survived cancer now for 7 years. But I really urge nurses, and all the kind people at the EAUN, that let's look deeper into this, and please look at the bits that you can't see. I often talk about this impact of a radical cystectomy and what happens. Many survivors, we carry the mental sadness of the loss of our sexuality. Our sex appeal and our drive, it is important no matter what. There are so many changes to our body and lots of questions to ask. It's not just beyond the scarring or the appearance of our body, but we have questions. Do you know, is it possible? Can I have a reconstruction? Is there a transplant available? What happens to me beyond my radical cystectomy? But this scarring, this stigma of the stoma, and this bag of wee that's constantly filling up, it has a time limit to when you need to empty it, or you run the risk of a bag burst. So how can you imagine what this contemplation, imagine you're embarking on sort of passionate sex. What happens to the bag? Does it get in the way? And, let's bring in the partner here. How does your partner cope? Should you consider wearing something to keep the bag in place? All these questions that from a patient's perspective we have. And now this is not just about attempting any sort of penetration. It goes way, way beyond that. So I come to this patient's perspective. I do feel that there needs to be so much research. I want to know who else feels like me. Have they been embarrassed in this need to ask for help? I always refer to this stigma. Am I meant to just give up and accept that intimacy should stop at my age? Is there any after cancer service? And where do we, as patients with a radical cystectomy and changes to our sexual functions, where do we go for help? So when I embarked on my particular operation, I was in an existing marriage and relationship at that point of the radical cystectomy. But it has such a great impact. And, now there's been a change in circumstances. And I have to look at this from the prospect of being single, alone, facing difficult conversations and possible rejection with potential new partners. Is this something our CNSs can provide answers to that are related to the female sexual well-being? I always come back to the fact that I am so alive, but sexually and everything else, oh my goodness, I'm quite dead inside and feeling quite emotionally turned off. Next slide, thank you. So this coping mechanism, and how do we cope? Okay, I refer again to this stigma. Am I meant to just give up and accept that intimacy should at any time stop, especially after major surgery? We look for counselling. What is offered? Where do we go? What's our first approach? And coping with the anxiety that we're left with. Where do we begin with asking for referral to a sex clinic? And does the embarrassment overcome so much that we think, oh, okay, I won't bother? I pointed out also that being in any existing relationship at the point of radical cystectomy will have so much of an impact, so many discussions that are meant to be had. But then we also look at people who are single and alone. Yes, they're alive. They're embracing being alive. But we look at then the ongoing and the well-being. Women's sexual health, like men's, is important to emotional and physical well-being. Sometimes I'm presenting and I'll ask nurses to perhaps walk in our shoes, see what it's like and feel how you would feel with the scarring and the inability to have penetrative sex. What do patients feel? Please always show empathy. And I now feel that it's becoming more aware, and this awareness for us to say, hey, come on, let's talk about sex. But it's this action, and where do we go from here? Thank you.
Thank you very much, Susan, for this very excellent presentation on how you experience your well-being, your life with living with the stoma and all the other problems you encounter. I think it's very educational for us as nurses and healthcare professionals. I want to proceed to the last presentation. That's a presentation from Marieke de Witte. She is unfortunately not available at the moment because she's on a flight to Budapest, but she has a pre-recorded presentation and that will be started by the staff. So we can listen to her presentation, and after this presentation we can answer questions from you. So please put your questions in the Q&A.
Good evening. I'm going to share my screen. So today I'm going to talk about the psychological aspects of cancer and sexuality. Now, in general, we see that healthcare professionals, patients don't talk about sex in healthcare, and this is really an unmet need, and it's from both sides. From the side of the healthcare professional, it's often barriers to talk about sex are due to lack of knowledge, lack of skills, personal shame and taboo, but also the idea that you would violate the privacy of the patient if you would start to talk about sexuality. Also from the side of the patient, there are some personal taboos and shame to talk about sex, but it is clearly an unmet need because from research we know that patients do indicate that they have concerns and questions about sexuality, but that they don't dare to bring it up themselves. And they also notice that their healthcare professional is not talking about sex. Why are we afraid and why are we ashamed to talk about sex? Well, we don't have a language to talk about sex. And this is a taboo that is actually installed already in childhood. Because from early age on, children are curious about sexuality. They explore their own bodies, they touch themselves, they find it very pleasurable to touch themselves. It has nothing to do with sexual behavior, but when they touch their penis, when they touch their clitoris, as a parent, we are shocked because we give this adult meaning of sexuality and we say, don't do it. We install a prohibition, a taboo. Also, when children ask questions about sexuality, we don't give an answer because we say, oh, you're too little. Don't ask these questions. I will talk about it later. So from childhood on, you learn you cannot touch yourself and sex is something we cannot talk about. So that is actually the main reason why this personal embarrassment about sexuality is installed and still lingers on throughout adulthood. We know that when you're open to talk about sexuality as a child, that you have a lower chance of sexual problems, that you have also a more sexual health behavior because of this openness to talk about sexuality. So it's really important to start opening up. Also in therapy, start talking about sexuality in healthcare and in general. Well, we follow actually the PLICIT model, which is a stepwise approach, and which means that it always starts with giving patients a permission, a platform to talk about sexuality. Then you can give some limited information, some specific suggestions, and eventually there's intensive therapy. And the intensive therapy, that's the job of the sexologist. But not every patient with sexual concerns or sexual problems needs intensive therapy. Sometimes it's sufficient to just bring up the team, explain it, talk about it, giving some basic information. And this permission is so important. And I feel there's an important role for nurses here because nurses are often much closer to the patient than, for example, the doctors, oncologists, urologists, gynecologists. So it's really the role of the nurses to start this conversation about sexuality. And it's proactive, which means that patients themselves, they may have questions about sex, but they will be like afraid to bring it up because they're here for a life-threatening disease. So they feel a little bit awkward to bring up the theme of sexuality. So that's why it's really important to start a conversation, and you can start it by depersonalizing, just indicating sexuality is an important component of health and of relational health. We know that in research that sex has an impact in daily life, and that also cancer can have an impact on sexuality. We know from other patients that the cancer treatment has an impact on their sexual responding. We know that there are still questions and needs about sexuality. How is it about your sexuality? So you start from depersonalizing, referring to research, referring to other patients, and then you personalize towards the patient. And that is a good way to introduce the topic without brusquing the patients too much. Now, when we think about the importance of sex, when you got this cancer diagnosis and cancer treatment, we often see several phases. It starts with sexual abstinence in the sense that there's kind of this idea of survival. You know, you have this life-threatening disease, so sex is not the first thing on your mind. But then there's the insecurity, like, okay, what is still possible? Exploration, sexual opportunities. Let's actively explore what is still possible. And then there's the phase of sexual stability. And sometimes sexual stability also means sadness and grief about what is no longer possible anymore. Now, a sexual situation is a social situation, which means that it's also about closeness and intimacy. Sex is more than only sexual arousal with the partner. And I think it's really important for patients to understand that the definition, the meaning of sexuality can change. Now, in most cases, the desire for sex returns after 2 years. So maybe in the first year, the first 2 years, there's not a lot of attention to sexuality. Maybe there may be attention towards intimacy, but not sexuality in general. But it's also about adjusting and accepting that there are some limitations and that sex may get a different meaning and may change. Now, we know in general that pre-morbid sexual functioning is the best predictor of sexual functioning after disease. Because if you have a couple with low sexual flexibility, difficult communication, maybe there were already some sexual problems, then the chances for sexual rehabilitation are lower. And it becomes a little bit a more difficult process because you need to learn them to communicate. You need to learn them to become a little bit more flexible. So always ask about their sexuality before the disease. Now, cancer has an impact on sexuality. We know the disease itself, but also the treatment, the medication can have an impact on the sexual response. And there's a high comorbidity with sexual problems. About 50 to 70% of the patients will report sexual dysfunctions, but also sometimes sexual adjustment problems, sexual concerns. Now, cancer has an impact the cancer itself, but also often the treatment and radiation. Radiation therapy leads to loss of sexual function, less energy, feeling less attractive, which is definitely the case for breast cancer and prostate cancer, because these cancers also affect the feeling of masculinity, femininity, and the sexual response. Think about loss of urine, involuntary loss of urine in case of prostate cancer, which can lead to feelings of shame, avoiding sexuality because they're afraid that they will lose their urine and stool during sexuality. Mastectomy, hysterectomy leads to feeling less feminine, but also prostate cancer often leads to ED, erectile dysfunction, especially when it was not possible to spare the nerves that lead to the erectile dysfunction. So they feel less masculine because an erection is often a sign of masculinity. But also think broader. Think about all the physical examinations that they need to undergo. And often these physical examinations are in intimate areas. People are constantly touching you. You constantly have to undress. So your body is not your own anymore. It's not your own private area. So you lose boundaries. People constantly transgress your boundaries. And then you feel that you're not an owner of your own body anymore. So it can affect your body image. It can induce feelings of anxiety, insecurity, and shame. Now, cancer has an impact on daily life because of the physical problem, but also the psychological factors and the relational factors, because there's a disturbance of the psychological balance, disturbance of the balance in the relationship. What we often see is that, for example, the partner at a certain point becomes the caregiver, doesn't see the patient anymore as a sexual partner. You don't feel sexy. So there's like no partner relationship, like no context for sexuality and intimacy anymore. Existential issues, you're confronted with mortality, can also interfere with your sexual identity. There are changes in daily life. You need to change the meaning, the function of sexuality. Sex may be less about personal gratification and orgasm and the physical response, and it might be more about sharing intimacy together, comforting. So what is really important to talk about with patients is the flexibility and the creativity, because these are key words if you want to rehabilitate sexuality after cancer treatment. It's learning to have sex again. And this starts with giving good information about sexuality, about how the sexual system works. Now, first of all, it's important to say to patients, there are very different reasons why people have sex. There are actually 237 reasons to have sex. So it's not only about physical gratification, climaxing, orgasm, about intimacy. There's so many stress regulation. It's about boredom. It's about a novelty. It's about so many different aspects. The main reason why we have sex is pleasure. So it should never be about the function, about what is still possible, about the frequency of sexuality. It's about the quality. It's about pleasurable sex. That's the main reason why we have sex. We want to have pleasure, and pleasure can have very different meanings. And I think the crucial aspect is, as a couple, is trying to co-create a context for shared sexual pleasure. So creating it together, and it's about sexual pleasure of both partners, shared sexual pleasure. Now, when we think about the sexual system, sexual desire does not pop up out of the blue. There needs to be a stimulus, something that triggers the system, a thought, a fantasy, a touch, a visual. Our brain automatically picks this up, which will automatically lead to genital arousal. So penile erection, erection of the clitoris. Now, this genital arousal says nothing about consent or desire or pleasure. This is just your body picking up a sexual signal. The moment you become aware of these signals, you assign a positive meaning to it and you expect something pleasurable, then the subjective sense of arousal will occur, because you expect something pleasurable, you want to engage in sexuality, you have the motivation to actually do something with the sexual stimulus. So this is really important. Yes, your bodily responses, and there's also your mental arousal, and there's kind of a feedback loop. And it's really important, if you want to attain this full-blown sexual response, the crucial aspect is the expectation of reward, the expectation of pleasure. If sex is not pleasurable, if there's no reward, you won't desire. And this is crucial. This is one of the reasons why we often say, oh, women, for example, and especially heterosexual women, have less desire than men. It's often because our sexuality is geared towards penetration, and penetration is not the most pleasurable aspect of sexuality. Also important is that sex is not spontaneous. Sexual desire does not emerge out of the blue. There needs to be a trigger, a stimulus. So there's nothing wrong about planning sex. Agenda sex. It's about creating the opportunity to have sex. If you want to go out in the weekend, you want to have dinner, you will also pick up the phone and make a reservation. On Friday evening, you will dress yourself up to go to the restaurant. So you're creating a context to have sex, to have a pleasurable evening. So it's the same actually with sex, creating a context, an intimate context to for sexual desire to grow. What we often see in relationships, that there's a mismatch in sexual desire. It's very unlikely to expect that two partners always want the same at the same time. So it's very normal that one partner will take the initiative. The other partner, maybe at that point, is not thinking about sex. But it's really about opening yourself for the sexual stimulation. So it's not waiting for the spontaneous desire, but when there's a sexual stimulus, don't ask yourself the question, do I feel desire at the moment? It's more about, can I open myself for the sexual stimulation? And if there's really a difference in frequency and also in what you actually desire, you can find a compromise, something that works for both. Like one time we do it more like you want, and the other time we do it more like you want. What is really important also is the good enough sex. There are a lot of images in in the media and society about passionate sex. Now, passionate sex is not realistic. Passionate sex is not sustainable. It's good to have passionate sex once in a while, but in daily life, it's not that common. Often sex is just okay. It's good enough, and there's nothing wrong with good enough sex. Pleasurable sex also means that sex is more than penetration. Again, our sexual script is often focused towards penis and vagina context. And when we think about pleasurable sex, we often think about orgasm, and then we think about orgasm during penetration. But pleasure is more than orgasm, that's one thing. And also, you don't need to reach orgasm during penetration. In general, there's a huge orgasm gap between men and women, in the sense that in heterosexual couples, men almost always reach orgasm, while for women, it's only 65%. And during penetration, it's actually only 30% of the women reaching orgasm. And this is often because we're not getting the right sexual stimulation, because we're focusing too much on this one definition of sexuality. So it's really important to broaden our definition if we really want to attain pleasurable sex, and especially when the physical system is challenged, then it becomes even more important to let go of the penetration and broaden your sexual script, because the ultimate aim is pleasurable sex. It does not necessarily need to reach orgasm. Important pleasurable sex means that also sexual pleasure can be attained via genital touching, oral sex, manual sex. And often this is part of what we call the foreplay. But foreplay always has this idea of being a bonus when you have time. So I think it's really important to stop seeing the female sexual pleasure as a bonus. The foreplay is actually the main course, not the appetizer, and the penetration is dessert. And sometimes you had enough and sometimes you want this little extra. So focusing a little bit more on the broader definition of sexuality. Women also want to climax, this idea that men only want to have sex and women also only want to cuddle. That's not right. I mean, both men and women want to cuddle, want intimacy, and also want to climax once in a while. So it does not need to be the ultimate goal, but it is also an important part. And so it's important also to explore yourself and see what are your preconditions to experience sexual pleasure. Own your own pleasure, and that is so crucial. Don't make yourself dependent from your partner, and that the partner is the one that needs to give you the sexual pleasure. Pleasurable sex is about finding the right sexual stimulation, what turns you on, creating a context to have sex, and it's about communicating with your partner, being open, because if you know what you need to find arousal and orgasm, then it's also important that your partner knows. So communicate to each other. And also important, if we think about sexual rehabilitation, especially after treatment, cancer treatments or after chronic diseases, treatment success should be defined by pleasurable sex and not restoring the sexual function or restoring the sexual response. It's about making sure that patients can have pleasurable sexuality in any possible way and not necessarily via penetration. The partner plays an important role. Cancer is a shared stressor, sexual problems are shared stressors, so it's really important also to include the partner. Both are suffering, so both are needed to solve the problem. And also not only treat the patient, the partner as functional to understand the patient, the partner in itself also have issues with shame and insecurity, avoids sexuality, doesn't dare to take the initiative anymore, is hesitant, suppresses their sexual needs. So it's really important to pay attention to the feelings and the sexual arousal and behavior of the partner as well. Shared decision-making, if you do treatment, if you want to rehabilitate sexuality, it's really important to bring both partners in the story and to explain it to them both. And giving concrete tips to relearn sexuality is, first of all, making sure that they understand that sex is not spontaneous, that they need to create sexual desire, so don't avoid sexuality. Often, because the physical system is challenged, you need more direct and longer stimulation. Maybe you can integrate sexual aids and try to plan sexuality to see which part of the days do we have more energy, which positions are less challenging. For example, spooning can be a good way to have sex. Just try to plan it, try to talk about it, and try different things. And just know that the way you had sex before may not be possible anymore. So you need to be flexible to just leave your sexual script. Communicate. What do you need? What is still possible? Sex is more than penetration. It's also about kissing, touching, caring. Not holding on to the usual. It's actually an opportunity to have more free sex. There's more freedom in sexuality because the way you had sex for 20 years, well, it doesn't work anymore. So let's try different things. It's also an opportunity to actually bring some sexual variation. Start with yourself, explore your body, what is still possible, and then you can integrate a partner and see what is still possible together. And it's also really about making time for each other, making time for yourself, because we know that feeling sexy, feeling attractive, paying attention to your body, especially because often the body image is damaged after cancer treatment, it's so important to make sure that you feel at ease with your own body again. So make the time to really care about yourself. Talking about anxieties and doubts with your partner, and then so important, creating this relaxing, intimate atmosphere. Make sure that you plan intimacy. It does not necessarily need to evolve towards sexuality. You can also have just this intimacy together, and that can also be very worthwhile. Also during the treatment process, during the recovery process, being intimate can really help to support treatment. So these are some very concrete tips you can talk about with your patients. And I think it's so important to overcome boundaries and to dare to talk about sexuality, because, as I said in the beginning, it's clearly an unmet need in cancer patients. Thank you.
Thank you very much, Marieke. Right now, but this is also, again, an excellent presentation on how to discuss the sex with your partner when it's becoming difficult due to problems you have. This was the last presentation. I want to go to the Q&A box. There's one question, and I think it's, I've read it already. I think it's a very good question. And that's about the sexual counseling. Should it be part of the standard care? That's very clear. But should we as caregivers start the conversation, and how do we start the conversation about the sexuality, as we have to give a lot of information in the preparation of the cystectomy to the patients? And how much time does it cost to start this conversation? I think it's a question we all are asking ourselves, working in urological cancer care. And that's not only for female patients, but I think also for male patients, an important question. Rebecca, do you want to start with maybe an answer to this question, as you have a lot of experience in this?
Yeah, of course. Yeah, sure. I think there is no set amount of time, you should dedicate to it. I think it takes as long as it takes. And there's a few aspects that we need to consider, I guess, if we're sort of talking pre-operatively. And, the most important one is informed consent. So it's very clear that, if you're going to be, performing surgery, you're going to be, changing a person's body, you're going to be removing organs, you need to be very clear about the impact of that on the individual. And it's not just sort of a case of, we will be taking this away, actually, what does that mean, for the patient in the post-operative period? So clearly information is fundamental to informed consent. And, part of that, I think, is about counselling about the impact of removing those organs or incising those organs. If we're talking about the anterior vagina wall, what impact will that have on that woman's sexual function post-operatively in terms of sensation and pleasure? Because it's not just the sort of physical function of, changes to the vagina. There's also the, the physical function associated with changes to sensation. We learnt from Jeanette's slides about the close relationship between vagina and clitoris, and all of that has an impact in the post-operative setting. And then talking about the post-operative setting, sorry, I'll keep my answer a bit more concise, but I think it's about establishing what's important for that individual, and working with them to establish, to set goals for rehab. How much information do they need, and when do they want it in terms of that post-operative setting? How can you facilitate that person's recovery? I don't know if Susan has anything to add to that.
Yes, Rebecca, thank you. From the patient's perspective, it's always sort of one step at a time. And it was touched on in the presentation that you initially get your diagnosis, and what you want to do is just survive. Everything else, whatever challenge it is, you'll pick it up later. And there was a good key element that said it's about 2 years for recovery, and then this perhaps return to sexual function. And it literally is that 2 years. I know from personal experience, because your body has to heal. There's all the emotional side, the anger. But when you are surviving, it's after that. And that's why I emphasize that from the patient's perspective, they must always be able to have their voice and to ask for help and to know where to go for help, and to release this taboo of the stigma that they can ask about sex and know where to go, because it is important from the emotional, physical, the feeling wanted, the returning back to normal life.
Yeah, and I think that's a very important issue you mentioned. Is what I'm questioning myself also, and maybe some of the audience. As Marieke showed us the pyramids on the permission, asking the permission towards the intensive therapy. And she also addressed the importance of starting the conversation before the surgery already. And as she said, the nurse would be a good person to start this conversation. So then, can you emphasize to this, did you miss some of that aspects which Marieke addressed at the start of your whole way from diagnosis towards the situation you are now in?
Yes, definitely. So I was given my diagnosis, and then there was 3 weeks to plan and have the full operation. So the surgery was booked, and in between time, you have a very brief meeting with a CNS, which lasted for about 15-20 minutes. And then, because you're facing lots of other dilemmas, mainly the changes to your body in terms of the stoma and how you're going to adapt to that, you do feel this embarrassment of not to ask about sex. It's briefly touched on also about, one of the questions was about where are you in terms of a relationship. So I expressed that I was married, but at that point, there were problems within the relationship, but we had agreed to put them on hold, get over the cancer, and then we'll address the problems within the relationship. And they go beyond that because everybody's so individual. And I can honestly say now that it won't only be me. There were other people that were perhaps having dysfunctional problems before they had their surgery, because it's quite common in a marriage, in a partnership, that these situations are there. So you try afterwards to again build up the communication with a partner to talk about things, but a lot of it again it's put to one side. The sex and this aspect is put to one side because you will focus mainly on your recovery and then talk about this. But this is the point where we must address how we return to the subject after the recovery process.
Exactly, and I think that's also a very important message. I think we can learn a lot from this, all this experience. That it's important to address the sexuality before surgery, but get back to it after the surgery. And I think us as nurses have an important role in this kind of aspects, and maybe not only the specialized nurses on sexuology, but also oncology nurses who have the most contact with the patients on oncological aspects. I have another question myself, Rebecca. Maybe you can answer this shortly due to time. How did you start your nurse-led clinic on recovery on cystectomy patients, but also addressing the sexuality in this clinic, and get the contact with the physicians to to convince them that this is an important subject?
Yeah, I mean, great question. So most of my practice happens concurrently, so within the existing consultant clinics. And I guess, I've been researching it for a few years, and I guess that sort of inherent interest in this aspect of care, and sort of identifying it as an area of unmet need. And I'm very lucky that that my consultant colleagues are kind of involved in my research as well, and they're very keen to address this area of unmet need within our practice. So yeah, I guess raising awareness, presenting the evidence, directed learning, and you get buy-in from your clinician colleagues in that way.
Thank you. Hopefully this will also convince the audience, some of us who have the availability to address this subject with patients, to get into this and promote it in our own practices. With this, I want to end this webinar. We're about 10 minutes over 8 o'clock. Thank you all for attending this webinar, and have a nice evening, and hope to see you again on a later time. Thank you.
Thank you.
Thank you.